Hello and welcome to another session of Voices in Healthcare Cloud. We are so excited to have two physicians joining us today from Baylor Scott and White Health out of Texas and Nemours Children's, Dr. Camile Bradley and Dr. Alfred Atanda, to share their thoughts, opinions, and experiences using technology for virtual health and asynchronous care to provide better outcomes to their patients and better well-being to themselves and their staff. So without further ado, let's do introductions. Thank you.
All right, everybody. Thank you for joining us today. We are so excited. My name is Shelly Avery from Microsoft. I'm joined by my colleague, Josh Thompson. Josh, you want to say hey?
Hey, everyone. Josh Thompson here, Microsoft Account Executive. Great to meet you, Dr. Bradley and Dr. Atanda.
Yeah, we are so excited to have two practicing physicians with us today. First, love Dr. Camile Bradley. Would you say hi and let our audience know who you are?
Yes, hello. I'm Camile Bradley. I'm a family medicine physician in Dallas, Texas with Baylor Scott and White. Began my career and my training in rural medicine, and then my husband convinced me that moving to the city wasn't so scary, and I've been here about 7 years. And about a year ago, took on some work within the organization around virtual health and innovative development and integration into practices.
Awesome. And Dr. Atanda, where are you coming from?
Hey guys, nice to meet everybody. I'm Alfred Atanda. I'm a pediatric orthopedic surgeon coming from Wilmington, Delaware. I practice at Nemours Children's Health. I'm the chief of sports medicine surgery out there, but I'm also the director of clinician well-being, and I work very closely with our chief wellness officer about 1 day a week, implementing different operational strategies to improve efficiency and to improve the work environment that our physicians work in so that they can do their jobs and appropriately bond and connect with their patients. I'm also highly interested in telemedicine and digital health, provider-to-provider consultation, and how we can really reimagine musculoskeletal care and how we can focus on moving knowledge and information as opposed to moving people. So very excited for this discussion. Can't wait to pick your brain a little bit more, Dr. Bradley, and see what you guys are doing out in Dallas.
Yeah. So you guys both were practicing. Or you still are, but you've both kind of taken on like this side gig to help your organizations do more with technology, do more for physician well-being. Tell us a little bit about how you made that transition and what kind of that side gig is that you're doing.
I know I kind of started it mostly out of frustration around inefficiencies and ways that I wanted to practice in my world. And I think they got tired of hearing from me and just gave me a title to make it official. There's just ways of connecting with patients that I could see this working really well. And I wanted to be able to reproduce that for folks that are either my partners, is where it started, and then now within the entire organization, of how to actually do this well, but for patients and for providers too. It actually is one of the nice things that is beneficial to both parties that sometimes have diverging conflicts of interest on time. So, but I don't know about you, Alfred.
Yeah, I mean, it's interesting because I think a lot of these things just evolve. For me, I was noticing a lot of frustration and inefficiency just around the care that we were delivering. I feel like at a large academic health center, you're very good at, doing surgeries and doing procedures and being at the cutting edge of like what's like the latest and greatest to help take care of people.
Yep.
But then the way people get scheduled and the people get navigated into and through our healthcare ecosystem is terrible in general. I don't want to just pick on my hospital because I think that's the U.S. healthcare system as a whole. And one of the things I was noticing is that was directly impacting our physicians, because if patients are inappropriately scheduled and seeing the wrong doctor at the wrong time or in the wrong satellite office or what have you, then that creates redundancy and waste for us doing the work, right? The bottom line is, though, in a fee-for-service model, we still make money. So whether or not I actually provide value to somebody, whether or not I've been stressed out and frustrated because I'm seeing somebody I don't need to or have the ability to see and take care of. If the hospital makes money, there's no real incentive to try to change that. And that was really frustrating me. And I think our hospital in particular kind of noticed that, and that's why they came up with these different roles for director of clinician well-being and chief wellness officers that are at least showing, some interest in trying to improve things. But that's kind of where this all got borne out for me.
That's awesome. You both mentioned these ideas around, I guess, a lack of efficiency. Dr. Atanda, you use the term kind of waste and some other things, but I'm curious. You talked about scheduling. So between scheduling, what are some other areas specifically where you were kind of focused in on trying to inject efficiency into the processes, into the day-to-day, and impact that clinician well-being, for both of you? And what does that look like?
Well, for me, the way I kind of got into this was we noticed that, we're getting a lot of kids that are being injured at outlying like rural hospitals and smaller hospitals and being transferred to us, mostly because the adult orthopedic surgeons would get nervous and they don't want to take care of kids, or parents would be nervous and they all want to come to the pediatric, academic care facility. The problem is when I looked at a year's worth of orthopedic transfers, I found that almost 40% of the time, the patients didn't need to be seen by us in the emergency room. Now, they may have needed to see us as an outpatient or something like that, but they didn't need anything in the ER. The issue is logistically to get somebody from point A to point B, they usually take them from one emergency room by ambulance and they bring them to our emergency room. So what we were noticing is that ambulances are very expensive. B, if we're seeing patients that could be managed as an outpatient, then our emergency room doctors in our hospital are seeing patients. They're dictating notes on these patients. The nurses and MAs are taking vitals and rooming these patients. And it's all waste because the patient would get seen in the ER, an orthopedic resident would kind of slog down at 2 a.m. and then just send them home. And then we'd see them the next day in the office. And we were finding that happens a lot. We looked at about 400 to 500 transfers in a year. So this kind of piqued my interest. And that's when I started talking about, the different wastes in the system. And that's how we then transfer that to scheduling, because then people were just, patients are online scheduling on their own. But they don't know, right? They just find a quick slot. They want a same-day appointment, and our hospital touts itself on providing immediate access, which I think is a good thing, but it has to be the immediate, appropriate access at the right time. So scheduling is a huge thing for me. The second piece is really a lot of the external regulatory pressures that we experience as physicians. So things from HIPAA, legal, compliance, different JCO, OSHA, AORN, all that sort of stuff. Yeah. I think most hospitals they want to mitigate risk. They don't want to be fined. So they interpret a lot of those rules and policies very, very conservatively. And we don't always do the best job at interpreting it through the lens, the people that are doing the frontline work. So there'll be some, leader will go somewhere, they'll go to some conference, like I'm at a conference here, they'll say, oh, I saw that this hospital got sued because doctors didn't do X, Y, or Z. Okay, from now on, every doctor is going to do X, Y, and Z. Thank you. Yep. And they get up and leave. And then I show up, and I check my email and I see that there's this new initiative and it just gives me more work to do. And that's just one small example, but that kind of thing happens hundreds of times per year in a lot of different facets. So, documentation, regulatory control, inefficient processes with scheduling, how we're seeing patients, those all just kind of, boil over and brim over to the surface with stress and frustration. So for me personally, that's where I try to focus a lot of my efforts. Obviously, there's so many other facets to that, but that's just kind of where I started on my journey.
Yeah, so I'm a primary care physician. So we function as taking care of a panel of people for their entire lives. That's the dream. And so you are supposed to be that first stop for those folks as they're trying to get in, and figuring out how to maintain that access when there's critical shortage of everything in healthcare. Right. And probably the most painful part of our healthcare system is how to get that care. And as us as patients have trouble figuring out when we can get that access in the right place and time for us. And then as providers, a lot of times that time and space that's best for the patient is not the time and space that's best for us and our families. And so trying to find that Goldilocks medium ground ended up being a big part of what we did during the pandemic. I was pregnant with my second kid in 2020, end of 2020 and 2021, and had a lot of pregnancy complications at the beginning of 2021, and had to be home 2 months earlier than I expected to. And while I needed to be there, I also didn't want to take any of that precious maternity leave time earlier than I needed to. And we can get into a whole other topic about maternity leave. But I ended up flexing into a completely virtual access point for our clinic. And there was a lot of converting of messages that were appropriate for it to video visits. And so anybody who needed to get seen quickly, I could hop on with, because all of a sudden I had some great access and availability from home. But I also could maintain a lot of my chronic care management, knowing that my MA was still in the office doing blood work or blood pressures, or I could send up folks for that nurse visit after our chat and get them the care they needed that way. And it allowed me to kind of maintain my practice slower. I mean, it was definitely not at 100%, but I was at 50 or 70% of what I typically do for a month and a half before I had my kid. And that was the shove that I kind of needed to prove to myself that I could do a work from home day. Because it's very scary to take that leap of really converting how I've done it always and how we've always done it. And it was a little bit initially, if you build it, they will come, just kind of made a day where I was working from home and doing a whole set of video visits. But with kind of strategic follow-up planning, whenever I see somebody in the office, a lot of times I'll send them out and say, hey, let's do a virtual follow-up to make sure this blood pressure medicine is working for you. Or let's see what your sugars are doing after we've added this. Let's set up a video visit in 6 weeks. And I find myself doing better chronic care management because I can have these touch points that the patient doesn't have to take time out of their day to do either. And I could get enough of my panel on a day that I could do this from home and save myself one day of Dallas traffic. It was great for my burnout, and it actually helped me manage folks better. I typically argue that we got good at video visits because it was the pandemic, and we needed to see the sick people in a way that kept them home. But those aren't the best visits for video visits always. The follow-up care, the mental health management, the checking in, because they've got so many medical problems going on. They come in with a list every time. If you see those people more regularly, then we tend to do a better job. And it's the sick people that I need to look at their throat and their ears that are better to see in person. And it's these diabetics and blood pressures and CHFers that just get tired of always thinking about their chronic diseases, and having those more frequent check-ins means they take better care of themselves. So I've gotten better compliance from patients with the follow-ups because it meets them where they are. They don't have to take the day off of work. They can take a 20-minute break and go and chat with me instead. And it's the whole demographic is willing to do it. I found we're still about 20% virtual and 80% in person. So I'm here. If you still want to come in person, yeah, you can still do that. But it's funny that it is 20% of my 19-year-olds and it's 20% of my 90-year-olds. It's not a age difference. It's a necessity. So some of my 90-year-olds are tired of going to the doctor, and they don't always have great transportation. And so they actually will figure it out. They FaceTime the grandkids all the time, that they can get in here and we can do a virtual visit, and they save them some of that transportation as well. So we found a way that allows me to kind of tailor my day a little bit more, but I also can meet patients where they are and just choose the right. It's the same thing that Dr. Atanda is working with. It's the right patient in the right space at the right time.
Right.
And that can be a whole bunch of new places now that we're incorporating this more.
Yeah, and I think to add to that, one of the things that I always tell people is that there are certain types of patient visits that lend themselves much better to telemedicine and digital health. Just like you said, a lot of the quick check-ins, follow-ups, lab result review. For me, it's like post-ops. Sometimes we do a lot of second opinions that way because they already have their MRIs, they have their X-rays, they're already scheduled for surgery with somebody else. They just want my opinion. I don't really have to examine them. They have surgery in 3 days. They just want to talk to somebody to make them feel better about the decision, that they've made. So really, utilizing telemedicine as like a one-size-fits-all approach is a very bad decision, because then you're going to get a lot of providers and patients who are unhappy depending on the situation. But having that wherewithal to realize that, it works for these sets of patients with these sets of problems, but then the other ones you reserve for in-person or what other methods, I think is something that a lot of people have been grasping. But when telemedicine first got big with COVID, people didn't realize that. And that's where a lot of friction and barriers to care were happening.
We had to use it for the wrong thing. Like, we were using it because we had to for those sick people to keep them home.
Exactly.
But that's not the best way to use this. And so a lot of people, that was the only taste they had in their mouth, was trying to figure out if a COVID patient had pneumonia over the phone or over video. And that can be tough. But I am a big proponent of patients have a good idea of what they need and what they want. And if they can make the correct decision, if they're giving the right options. And so building something, creating this space in your day, in your practice, they'll fill those spots, especially if there's access issues, which there are always access issues. They'll be excited for a way to get that care, even if it is something that is ultimately for me as the provider.
And Dr. Bradley, I'm just curious. One of the things, again, that I've been really pushing is, outside of digital health in a direct-to-consumer fashion, I really think that the future of healthcare is with provider-to-provider communication. So finding ways that's not burdensome, obviously, but that's easy for frontline docs and primary care folks, ER folks, urgent care folks like yourself, to get a hold of someone like me. And get access to my knowledge, my information when you need it the most. And I think the biggest barrier is people want me operating and doing procedures and seeing patients. They want me making money. But being able to engage with someone like you and help you navigate your patients along the continuum of their healthcare problem and give appropriate expectations and tell them what they're going to expect when they come and see me, decide who needs to see me, who can stay with you. Have you all experimented with anything like that? I know we get a lot of epic messages, but
been reading my diary? Yes. So we do this. We call it an e-consult.
No, I haven't, but
I know.
Oh yeah, e-consult.
Yeah.
Sure.
So we call it an e-consult. It's a formalized curbside, is what is my catchphrase. And
can you do it through your organization?
Yes. So we're in development of each specialty as we go, and it's something that I've taken on with this role. But it is expanding some of the scope. I mean, my favorite quote is that because my grandfather graduated from medical school in the 50s. And when at that point, with the medical knowledge you graduated residency with, the doubling time of medical knowledge was about 30 years. So you could do your whole career with the information you left residency with and do a decent job. The doubling time of medical knowledge in 2020 was 73 days. It is impossible to keep up with the level of care that is, the appropriate, most up-to-date, thorough care with the breadth of care that primary care needs. And so there's a lot of ways you can attack that problem. But one of my favorites is something like a provider-to-provider consultation that allows me to gut check either a plan or a more specific situation, because there's always a lot of gray in medicine too. And kind of let me manage it from there on. I think all primary care doctors have control issues on some level because we end up wanting to take things over. But it is another way of kind of maximizing the patient's access in the most efficient way possible. And there's a lot of things that make that work. And some of that is the communication piece, being on the same EMR, making sure the charts are available, that kind of stuff. And then a lot of it's just kind of getting used to that idea of practicing where it is a little harder for me to take the plan and execute it and explain it to the patient. But there is a certain acuity level that is very appropriate for that. And if we can then fill your schedule with the higher acuity, tough cases that need that more long-term management from the specialist, and that's who I want in there. I want that availability for my sicker folks if I can handle the simple stuff. And then eventually, I have learned some things along the way too. There's some things that I've gradually incorporated into practice, like, oh, I've seen this, I've read this story before, and I think I might even know what the guideline is right now. But there's a lot of ways that we can incorporate that virtual piece that's not just involving the patient, but involving all of us just trying to take care of the patient.
Yeah, and I don't know if Microsoft does anything like this, Shelley and Josh, but I work as an independent contractor on the side for about 6 or 7 different companies doing e-consults, which is it's asynchronous, it's over email. But what I'm really trying to push is trying to make it synchronous. So, think of it when you have like translation services, you have a patient that comes in to see you, they don't speak your language, you pull up an iPad and there's 20 different languages. Imagine if you can do that as a primary care doc, but they're specialists. And you hit a button and boom, I show up. Hey, how you doing, Johnny? Oh, it looks like you have a distal radius fracture, and I go through everything. I manage their expectations. I get mom's questions answered. I help Dr. Bradley and educate her a little bit. All the while, I may get paid a little bit for it. The patient gets what they need. They don't have to go see a specialist. Like that's like where my brain goes.
I love it.
And I know a lot of folks aren't doing anything like that, but I like how you at least are doing it internally, because we don't even really have that at my hospital. We get Epic messages and emails, and it's
brand new. So it's one of those things that because it's just that pressure, that access pressure that we're seeing over every piece of healthcare. So any way you can get creative about it, we're willing to try.
So I do have a question for you guys.
Yeah, Sean.
It sounds like you both have figured out a way to fit virtual care or asynchronous care into your day and into your week. One of the challenges that we hear with implementing kind of virtual health or telehealth is all around the EMR and the ability to schedule. I'd love to understand a little bit, like Dr. Bradley, I hear you might have a day where you're like, these are my virtual visit slots, and Dr. Atanda, I know you had mentioned, I think you might do them at the end of the day. So you even talked about like send the rest of your staff home. Would love to hear a little bit about how you do that, and not just how you organize it, but how you update the EMR to inform others. So like if a patient is going to self-service schedule or someone's going to schedule on behalf of them, how do they know that that's when you're doing virtual visits so they can schedule it appropriately?
Yeah, so for us, it's, we use Epic as our EMR, and the templates are built such that there's different appointment types. So there's like a new visit, follow-up, post-op, whatever. And one of them is telemedicine. So anybody who's scheduling from central scheduling, which I don't necessarily agree with central scheduling. I think local scheduling is much better. That's a different podcast. You can see that my telemedicine visits are available. So if I have a full day of clinic, I usually have the last 2 or 3 slots of the morning and the last 2 or 3 slots of the day, like in the afternoon, as telemedicine visits. So it's built in, anybody can see it, even parents that are self-scheduling. And just like you said, like I like doing that because in the last patients of the session, then my staff can get a jump on emails, they can respond to portal messages, they can get lunch early if it's in the morning, or they can leave if it's in the evening, and I stay and just kind of, because most of it's follow-ups, patients that I know, the visits are quick, the notes are quick, I'm just chatting with them. But I think, I just kind of developed that over time, this little workflow, because it helps me still do the virtual visit. It keeps people out of the office, but then my staff, it's like, okay, 4 o'clock, he's got 3 telemed visits, and then everybody leaves, as opposed to staying, till 5 or 5:15. So that's really helped us a lot. But long story short, yeah, it's built into Epic and the template, and we kind of design it such that anybody can notice and realize where those visits are.
I try to do something similar because I do the work from home day, and I think that keeps my MA with me. She has a day that she can catch up on things and clean things up and scan what she needs to and do all of that stuff. But I do video visits on the regular days too. And the hard part initially is the one finite thing we have is the time in the day. And trying to really hardwire your schedule as much as possible to what you are capable of seeing on that keeps your mental health okay, so that the availability is there. The patient can schedule that if they want to. We try to have open scheduling online too, so a patient can get that access as much as they can, but not hiding spots that we would save or something like that along the way. I'm notorious for adding video visits to my lunch hour. I will not sacrifice my MA's lunch hour. But if we've got some messages that came through that need to be some quick video visits, we'll tack those onto the lunch hour and just kind of get them through. I did figure out, and this is a double-edged sword, how I can schedule my own on. You get your access on your EMR to do your own scheduling. And so I'll often in the morning just send off a message to a patient that says, hey, let's chat about this. I'm putting you down for 12. Let me know if that doesn't work for you. And then we've got that all going with involving the least amount of people to try to keep that efficient. That's not always great for my mental health because that lunch break is a decent time frame for catching up on things. And so I do try to hardwire it as much as possible so patients can see where they can go. But there's just a high access need. And so sometimes we're overbooking in strategic places to get those patients seen. But on the patient end, they're much more likely to be able to make that appointment that I gave them an hour's notice for if it's a video visit over coming into the office. It's a lot easier to rearrange their schedule to accommodate that. So it means that we can just hop on together, especially if now that we've got at-home testing for COVID, they send me a message and like, Doc, I'm positive. I'm like, okay, let's hop on a call. Let's make a plan. What medicines make sense? And we're able to, I often do those. I'm like, about to call you. And so we just get on and get it done. But that improves that on-demand access, which is really tough to keep in primary care, particularly. Although I bet it's not easy in sports med either.
Not necessarily, no.
No.
Dr. Bradley, do you have any thoughts about patient navigation via telemedicine? So I know we throw that term around a lot, but what I really mean is filling in the gaps of episodic care, right? So if I see you today, then I tell you to come back in 3 weeks, then I tell you to come back in 6 weeks, and I tell you to come back in, 8 weeks. I see you at these touch points, but your problem in your life continue 24 hours a day, 7 days a week in between those touch points. And I get paid to see you at those touch points, but the day before you show up, I don't have any incentive to interact with you and make sure that you have the appropriate MRI done, or you bring the disc with you, or afterwards, make sure that you understood what I was talking about, where to go get physical. Like there's so much value in that, but it's not reimbursable. We don't get paid for it. So it's out of sight, out of mind. Like no physician is going to really think about what's happening to their patient in between episodes of care. I've always fantasized about utilizing telemedicine and digital health as like a digital, patient navigator. Like they touch base with you every couple of days and like, hey, how are you? How's your wound? How's this? Because if you preemptively engage with people, you're more proactive and you're not waiting till like their wound is red or their knee is swollen or this, and then they freak out and go to the ER unnecessarily. But you're constantly just touching them and engaging with them and just kind of navigating them along. And, I wish it was like a real person that's doing this face to face. That
Yeah.
might be cost prohibitive, but even if it's like a chat bot or if it's like an automated message, something that can
Right.
kind of interact with people and catch them before there's an issue. Do you all do anything like that or have thought about that?
We're looking into something. I mean, the obvious things in primary care are the biggies, the diabetes and CHF and hypertension of chronic disease management, and that ain't ever going away. And if I see a diabetic 4 times a year, how involved in their care am I actually participating,
Right.
And at the same time, weighing the fact that we just have critical shortages of providers as it is for primary care in particular, and wanting to maintain some of that longitudinal contact. I think some of this is a brilliant place for automation, and using human behavior psychology and nudging, and knowing that a patient is not always going to want to hear about vegetables the week after Thanksgiving because they've got a whole lot of guilt associated with it. Love getting A1Cs in January. You get all of the sob stories from the last couple months of holiday eating. But that there's a way to meaningfully engage with patients in between those episodes that is actually more preventative, which is why I do what I do. I don't want to be reactive. I want to prevent the stroke, the heart attack, the diabetic foot amputation 15 years from now. And it's tough when those outcomes, like my best outcome is something that never happens in a decade. And that's a tough thing to keep in mind when you're trying to manage all the things getting thrown at you every day. And I think there are parts of what we do that are very algorithmic and can get the right patient in front of us when they need to be there. And how do we engage with the patient so that they'll still want to engage? I'm always a little terrified of them unsubscribing to anything. There's a sweet spot of annoyance that is positive and whether they disengage. And also sends up those red flags when they need to get sent up. And so that way I'm not spending my whole day seeing people that I didn't need to when there was, 4 or 5 of my patients starting to get critically ill at home.
Right.
There's a lot of fantasizing for me on that end of getting a smart way of extracting the pieces of information that I do in a room and, trained a long time to figure out how to get that right history out. It is an algorithm. Like there are discrete pieces of information I'm looking for there, and doing it in a savvy enough way that a patient doesn't feel like they're getting questionnaire to death. It's somewhere in between there,
Survey overload. Yeah.
Yeah.
Yeah, I mean, that's something that I always struggle with. So when I see people, obviously my patients are different than yours. They're kids. They're typically healthy. But I've always noticed that everybody needs something, right? There's a reason and an agenda, at least for me, why kids come to see me. And it's not because their knee hurts. So if we create algorithms and plans that are around chief complaints, we don't really get to the bottom of why people show up. Some people show up because their athletic trainer at school told them that they have to see an orthopedic surgeon, or they saw an urgent care doc and they said they have to see an orthopedic surgeon, or mom is just so nervous and neurotic and she's feeling guilty about her kid limping around, she has to see an orthopedic surgeon. Or I see people who I saw mom and dad aren't together and mom told dad something, dad doesn't believe it, so then dad brings the kid in. So everybody shows up for a reason. And it's not because of like their medical problem. It's because of what they're seeking, what they want, what they need. And this whole idea of like navigating patients, like imagine if you could figure out what they actually needed before they showed up. You had a coach or somebody that could chat with them the day before, so that when they do show up, I can give them what they need. And I don't go through, so why does your knee hurt? When did it start hurting? What makes it better? What makes it worse? Like, no, it's a tailored visit. Oh, you just want an MRI? Well, listen, I don't typically order MRIs for these problems. And this is the 3 reasons why you're not getting an MRI. But you don't want to go through a 25-minute visit just to discover like, they just want an MRI because they're worried about what's going, you know what I mean? And that's what really frustrates me because I'm smart and I know how to do a differential diagnosis and solve people's problems. but I'm terrible at delivering healthcare. Like, I'm terrible at giving people what they need. I'm terrible of satisfying people's needs and goals, not because I'm a bad person, but because I was never trained to do it. But more importantly, I don't get paid to do it. I don't have the time to do it. And everything in my infrastructure and system is set up to deal with people when they're standing in front of me.
Right.
So I always just wish there was that kind of world where I'd get like a paragraph blurb. Hey, this is Johnny. Mom's a little off. Dad's this. This is why they're here. This is the MRI they want. And then I can just, it's like you go on Facebook or Instagram, the ads are tailored to you. That makes your experience and your journey. That's why everybody goes to Facebook and Instagram, because they feel like they're in this like magical world and everything is about them. Whereas healthcare is the direct opposite. You show up, you see a doctor, they've never seen you before. They don't know why you're there. They're busy, they're pressed, they're under stress. They have to get to a meeting at lunch and they have to solve all your problems in like 15, 20 minutes. And that's why I come to a conference like this about burnout, because this is where all this comes from,
But I think it's we usually give patients 2 minutes before we interrupt them. It's something shockingly short of a patient narrative before we're like, hold on, I have a list of questions I need to make sure I answer the answers to based off of this word you said. And is there a way that we can get a patient to deliver that narrative in a human way that gets me the information I need, but more importantly, gets the real reason out quickly, and then I can start there, and then we can address things as we go. Because that's the classic primary care is the handle questions, what we call it. Like you're on the doorknob trying to walk out, and they're like, "There's one more thing that I didn't have the courage to ask yet until you're leaving." And this is my last minute to get it out there. And I just did the whole visit and we didn't address what you actually wanted to address. And that's frustrating for everyone involved.
Everybody.
And so smart visit planning that can happen before the patient gets there, like that's pretty brilliant. Yeah.
That's what I'm hoping to achieve.
Do you guys think patients or parents or family members of the patients, if the patient isn't able to, would be willing to answer questions or elaborate on? Because I know I always fill out like new patient paperwork or why are you coming, right? But it needs to be like more than that. Like,
I don't want to fill out my medical history 14 times. If you if you have all of that, what surgeries I've had or whatever, then don't ask those questions and get to spend the time on really getting into it. And that's where allowing the patient the free text space to do that sort of thing, but having something filter it for you before it gets to what I need to see to be efficient and get down to the problem. There's somewhere in between there that, because nobody wants to click through another questionnaire. But they do have the reason they called. And it may be foot pain, but it may be foot pain and somebody in my son's class was just diagnosed with a sarcoma, and so then you're like, oh, this is another question. Yeah. And that helps if they can say that in a way that level sets when you're first starting a visit.
I almost think of it as like more business. Now that I'm hearing you guys, it's almost like when I show up to a business meeting, I always want to say like, this is the agenda I have put together today. Are we all in agreement? Or this is the goal. What are your expectations for the meeting today? It's like, if the patient could tell you ahead of time, the ultimate goal I want to know is the foot pain, equal to this. That's what I want to get out of this visit. I love that.
I also like the idea of not just leaving it up to the patient, though, like having a member of your clinical team. I prefer it to be me, but again, my time is valuable. But having an experienced, knowledgeable member of the clinical team who knows me, who knows my practice, who knows the way I do and say things, interacting with that patient and coaching them and being like, oh, you think you have osteosarcoma because your foot hurts. That sucks. However, these are the kinds of things Dr. Atanda will do and say to you tomorrow to make you understand that you likely don't have it. Or you know what? Why don't we go have you get an x-ray or an MRI beforehand, because it'll be a clinical person that can do that, such that when you do show up, you've had the necessary scans. I've looked at them. I have the reports. I have the images. and I can just sit you down and say, listen, these are the 3 reasons why you don't have osteosarcoma, because that's what's most meaningful and valuable to the patient. Because like you just said with your agenda, this is what I want, this is what I need. Unfortunately, when they call and a non-clinical scheduler schedules them and they put in the Epic notes, they're here because of foot pain.
Yep.
In and of itself, that's helpful, but it's not really helpful for me in the short amount of time to get the patient what they need. And I feel like putting a little bit of that effort and resources upstream will significantly make the visits quicker, make them more streamlined, allow me to give patients what I need, make me, because nothing is more frustrating than you go in circles as a patient, and then you realize that all they want is like some test that you're never going to order. So now you spend 25 minutes talking to them and they want some test. You're like, well, you're not getting an MRI. All right, see you in 6 weeks. Now they're upset. They've spent half their day coming to see you and they didn't even get what it was that they actually wanted. Not saying that you always have to give them what they want, but at least let's cut to the chase and start working on those sorts of things the second you walk in the door. Maybe even you check in and you get like a text saying, hey, we noticed that you're here to see Dr. Atanda for your foot pain and why it's not cancer, or X, Y, or Z. We understand your concerns. Oh, here's a quick video that Dr. Atanda made on YouTube about why you don't have cancer. Why don't you watch this in the waiting area for 3 minutes? There's so many things that we can do. And, a huge company like Microsoft, I think, a lot of large companies that are in the healthcare space don't do that sort of stuff. They focus on the communications, they focus on documentation and the billing, but really reimagining how we're delivering healthcare from lowly doctors like myself. I preach this stuff all the time and people hear it and it goes in one ear and out the, oh, there's Dr. Atanda again, but, hopefully we can have further discussions with you all to see if that's something that you'd be interested in piloting or trialing. I'd be all for that.
And for the IT people listening that think that there's nobody like Dr. Atanda and I in your organization, there are. If you're used to working with the low adopters and the more conservative docs, there's somebody out there who is doing some weird stuff in the best kind of way. And if you can find them, if you need that innovative viewpoint from a practicing clinical physician, we're everywhere. We may be quietly doing our own thing in a corner, but we look at the codes, look how people are billing, if they're doing more telemedicine, if they're doing more virtual visits, if they seem to have some efficiency figured out on the back end. Those are the people that can help you innovate and push and convince our clinical brethren that this is a decent way of doing things. But every organization's got a couple of us mutants that want to do this a little bit different. A couple.
Well, I don't know, Josh, did you have maybe a last question?
I was just going to say, I think I love the energy, the engagement, but also the mind reading that's been going on here. I know Dr. Atanda earlier was reading Dr. Bradley's diary in terms of some of the questions he was asking. And I think Dr. Bradley right there.
That was only once.
Okay. Dr. Bradley, you were just reading kind of Shelley and my outline, I think, and where we wanted to kind of wrap up the conversation. So I really appreciate that. And I think that was ultimately where we wanted to end, right? Was what advice, clearly that diary comment earlier, it illustrates that people in different organizations, different parts of the country have similar questions and pain points.
We all got the same problems. Like we're all banging our head against the same wall. And it's just, how can you be your most powerful against that wall? And it's going to be different for every organization and potentially even every provider. But if you're able to customize enough to the patient panel and to the provider and allowing everybody to practice that works well for them, it's going to create a much more sustainable environment than we've seen thus far.
For sure.
Love that.
Yeah.
And I don't know that I have anything else, Shelley. I'm not sure if you have any questions, but
yeah, I mean, we just super appreciate both of you. from what you're trying to do. We need more people out there like you, changing healthcare for the better, because we need patients, and we need physicians, and we need the staff. And so we appreciate you guys both being here, partnering with us today. And we're excited to come back and see how we can help impact some of this change that you guys are looking to implement. So thank you so much.
That was fun
Thanks
hanging
for
out,
having
Dr.
us.
Atanda.
Yeah, nice to meet
It's
you
nice
too,
to hear
Dr.
other
Atanda.
people doing the same things. We're going to figure something out someday.
Someday.
Keep banging our heads.
Mhm.
All
All right. Thank you, guys.
Thanks, y'all.
All right, take care.